All right. So welcome everybody to our Dental Sleep Profits Mastermind training. We got Dr. Cuffy York here once again. He is going to be talking about sleep workflow, the ins and outs of consultations, home sleep tests, insurance, treatment, follow-ups, and adjustments, every peg in the process. So I'm really excited about it. And if you guys have any questions, if you're seeing a recording of this video, go ahead and just post the comments, post your question in the comments and tag Cuffy if you'd like an answer from him in our group. So that way you can still get your questions answered if you weren't able to make the call or if you arrived late. So Cuffy, I'll let you take it away. And I guess, we'll just start at what your workflow looks like in your office, maybe a high level view, and then we can start digging down into the individual aspects of it.
Well, obviously in different type of sleep practices, there's different scenarios. Because I'm a sleep only practice, I have no patients to draw from. Okay. So my first step in the workflow would typically be geared towards someone that has a general practice. Okay. You have patients in your practice every day that you're seeing in hygiene, restorative, and things like that. So every patient, we start out with screening, step one. Okay. You have to screen people. Just when COVID started last year and they said, we have to test. Well, if you're testing, you're going to find positives. If you're screening, you're going to have people that are likely to have sleep apnea. So you want to get the screening forms out there. You want to do your sleepiness scale, your Epworth. You want to get your bed partner questionnaire out there. You want to get your stop bang form out there so that they can fill these things out. Each one's going to tell you a little bit more information about how far along they could be towards having sleep apnea. And also too, you want to look at their health histories, because we know that people that are on one or more blood pressure medicines, people that maybe have type 2 diabetes and are taking metformin, people that are a little heavier, all these people are people that would be red flags for sleep apnea. So Step one in your workflow, screen.
Yeah. And are those forms you mentioned, like the Epworth, stop bang, bed partner, are those things that people can access online? Those are readily available?
Got to do is type into Google stop bang form. All you got to do is type in Epworth sleepiness scale, all this, and they're standardized. So an Epworth in California is the same Epworth in West Virginia.
Perfect.
And they're listed on Epworths are 0 to 3. How likely are you to fall asleep watching a movie? How likely are you to fall asleep after lunch with no alcohol involved? How likely are you to fall asleep reading a book? And if you're 0 to 7 on that scale, you're somebody pretty much doesn't have sleep apnea or doesn't have daytime sleepiness. Then if you're 8 to 10, getting close to 11, you're someone that's pretty normal. Okay. Anything over 11, you're likely to have sleep apnea or daytime tiredness. Now, I keep saying likely to have sleep apnea because we don't know you have sleep apnea until we do a sleep test. Okay. But you're someone that red flag ought to be at least raised, that your excessive daytime tiredness. And that's what insurance companies look at. When I hand these things out to my patients, it's so funny because I think they're afraid to put the true answer. So they'll put down 0. They'll put down 1. And I walk out of the room and I hand them this and I say, now, you're here to be treated for sleep apnea and we're trying to get the insurance company to pay for this. They need, and I look them in the eye, they need to see at least an 11 on this score to pay for it. You understand? Okay. 11. And I walk out of the room.
What? That's actually a really good tip. That's a really great tip.
It's 13, so I can see them in their mind just add it up, So yeah, but if you don't, they have to have comorbidities. So if you put down you're a 4, then they want to see high blood pressure, they want to see diabetes, they want to see overweightness and things like that. Okay. So I can't say enough about screening. Every single patient in your practice needs to be screened. And typically when I say every patient, I mean 16 and older when they have their permanent teeth. But if we have young children, we're still going to look for airway problems in our young children, and we may not treat them with an oral appliance. We may send them to an orthodontist and an ENT and things like that.
Yeah.
But, our job is to treat patients, and no matter what it takes, whether it's to refer them out or do them ourselves.
Yeah. Yep. Okay. So screening, step 1.
Yep. Now, we move from step one. Let's say we've got somebody and the bed partner questionnaire says the wife says he snores all the damn time. Sorry, I shouldn't say that. Wife says he snores all the time. His Epworth sleepiness score is a 13. He's got stop bang is up there pretty good. So now you say, okay, I want to do a initial consultation with you where we're going to run a couple of tests on you. There you go. Step number 2, we're going to do a consultation on you. And with that, we're going to measure their airway, and we're going to show them what a standard airway is. On a man, it's 3.2 centimeters. On a woman, it's 2.8 centimeters. Okay. So once we do an initial test, we show them what their airway is, and it may be a 4, which is okay. That means they have a big airway. Yeah, I've seen men that had 2.5s. That's okay. They got a small airway. The problem with starting out with a small airway is we don't have a whole lot of room left to collapse. So if they collapse 1 millimeter, they're down there pretty low already. If you start out with 4 and you collapse 1 millimeter, you still got a pretty big airway. Okay. So we want to show them that. Now, what that machine does is it gives me some positive proof to show them that they've got a problem besides their screening forms. Now I want to move them into step 3. I want to send them home with a sleep study, okay? A home sleep study. Now, many states, you cannot dispense a home sleep study, so make sure you find out what your dental board regulations are within your state, okay? If you can dispense one, have watch pads, have respirers, have whatever it takes in your office to send them home with a sleep study. All right. Now, if you can't, you want to send them to their primary care physician, and you want to get the physician to request a sleep study, and hopefully it'll still be an HST and they won't have to go to the hospital or a sleep lab and go to a polysomnogram.
And do you recommend, now you mentioned sending them to their primary care. Would you not refer them to an ENT, or in what situations would you send them to an ENT or a pulmonologist? How do you decide who to refer them to?
Well, I want to refer them to somebody that's on board with me. Likely, if you send them just to an ENT or the pulmonologist, you're going to get a CPAP. Okay. You know, I've said this analogy to you before. When you're a hammer, everything looks like a nail. All right. Mm-hmm. People, they treat even this one I work with here in my town, she wants to put everybody on a CPAP, mild cases, moderate cases. And the only time she really considers me is when they can't wear the device. All right. So, you know, American Academy of Sleep Medicine said in 2017 that mild and moderate cases should be considered first for an oral appliance.
Yeah. So first line of defense. Yeah.
Severe cases should be considered when they're CPAP intolerant. But she doesn't see it that way. She thinks everybody ought to have a CPAP, so she's a hammer. Okay.
Yeah. She's a hammer. Okay. So you recommend primary care as the first source for referring your patient out to, because is there an easier line of communication with their primary care as well, do you think?
Yes, I think typically there is. And usually what I like to do is once I find out who somebody's primary care is, I reach out to them before the patient goes to see them. And I'll tell them that, you know, hey, I'm Dr. Cuffy, work with Almost 7 Sleep Solutions, and I treat patients with sleep apnea who cannot wear a CPAP or have mild or moderate. And I'll say, I'd like to fax some information over to your office. And oh, by the way, our mutual patient, Mrs. Jones, birthday 5/4/54, is coming over to see you. And I would like you to administer an RXA home sleep test for her. And if they know what I'm talking about, they do it. If they ask me questions, I'll say, oh, you know, it could be a watch pad, it could be a respire, it could be a Aries home sleep test. Oh, by the way, I have these. So, you know, we can do that once you give me the order. Okay?
Yeah, that was my next question is how do you decide whether to send them to their physician for the sleep test, or a physician for a sleep test, or check a home sleep test out of your office to your patient directly?
We want the process to go as smoothly as possible without delays. And we have found that every time we relinquish control of the patient, we have delays. So it's the primary care may be slowing down, or if he had to, maybe he had to see about getting the tests or something. Well, he doesn't know how to, because he doesn't do those on an everyday basis and things. So we try to go ahead and have control of everything we can as long as we can. If we don't have to see a primary ahead of time, we go ahead and do the test, because in West Virginia, I'm allowed to dispense the test.
Yeah.
Yeah.
Okay. So it's really about understanding your state law, whether
Right.
you're allowed to dispense that home sleep test or not.
Correct. Um, Remember the guy that I went to Tennessee here recently and did?
Mhm.
Well, his state said he could not do that. All right.
Yeah.
So he's going to have to send everybody out to, and he's got some good physicians and stuff that said he can work with and everything. So that's a good one right there.
Yeah. And the great part is if you're a member of Dental Sleep Profits, you have leverage going into those conversations with primary cares. You can say, we have 60 to 100 people reaching out to us every month about obstructive sleep apnea. Are you available for me to refer you more patients who possibly don't have a primary care that they see regularly?
Absolutely. Yep.
Yeah.
Absolutely.
Okay.
So
So primary care is your best source to refer out to for a sleep test if your state doesn't allow you to dispense those yourself.
correct.
Okay,
Yeah.
great.
All right. Somewhere in between step 2 and step 3, you've got to get some insurance verification. Okay.
Mhm.
Uh, I like to get mine actually before I do my consultation. I'll tell the patient, I'll say, listen, you have medical health insurance. Oh, yeah, got Blue Cross. Okay. Send me a copy of your Blue Cross card. Send me a front and back. Also, send me a copy of your driver's license just so that I can verify that you are who you are. And we go ahead and verify the benefits. We find out, do they have out of pocket? We find out how much is their deductible, how much have they spent, how much is still remaining, and things like that. So that when I'm at my consultation appointment, I've already got a good idea that, hey, if it's not going to cost them anything out of pocket, we got a good chance at moving forward. If I get to a point where somebody maybe has a $4,000 deductible and they've already spent $1,000 of it, and I got $3,000 still remaining, that might be a hurdle that I've got to try to overcome. So then I start thinking of my cash prices and things like that. And that's what comes into the consult and case presentation. Okay. When we get to that next step. Okay.
Yeah. Now in that process of verifying benefits, all of those steps. Now, I know that in your experience, you have handled medical billing, you've outsourced it and you've handled it in the office as well, right?
Yes. And
So for our members of Dental Sleep Profits that are currently outsourcing that, what are a few companies that you have trusted in your sleep career that have handled medical billing well for sleep?
well, I think mostly everybody out there does a good job. There are problems that they're going to face that maybe cause delays, or maybe someone makes a mistake. I know Sleep Group Solutions has a billing company they use within their company. I know that DS3 down in Bradenton and Tampa has 4-pillar billing where they do it out of their company. Then there's an independent companies, Brady Billing in Texas.
Mhm.
They was who I started out with originally. And then there's GoGo Billing in Phoenix, and a couple sleep doctors own that company, and they do it very well. And then there's Pristine Billing. So there's a lot of sources and uh, people out there that can help you when you're first starting out.
Yeah.
Just asked by a doctor the other day about, how do I know when to start doing my own billing? Okay. And I said, well, number one, comfort. When do you feel comfortable doing it? But number two, are you doing enough sleep cases? If you're only doing 2 or 3 sleep cases a month, you don't want to go through all the hassle and training of having someone do all your own billing. Okay.
Yeah. Yeah. You got to justify that payroll.
Exactly. So now when you get to 7 to 10 cases a month that you're doing them on a regular basis, most billing companies, you pay 10%, okay, of what is billed through the insurance. All right.
Mhm.
Uh, I'm getting on an average about $3,000 a case, and I'm getting $20,000 worth of insurance coming in. That's not part of copays and things like that. So you're paying $2,000 a month to that insurance billing company. Okay, well,
Mhm.
right there, payroll. I mean, if you're paying somebody $18 an hour or something like that, that's about $1,000 every 2 weeks. So there's $2,000 in a month. That pays for your billing service right there.
Yeah.
And that
Yeah.
employee, when they're not doing billing, they're doing other things in the office that are helping you out too. So
Exactly.
7 to 10 cases. And I think that if you're in my situation where you're doing 17 to 20 cases a month, you almost have to do it yourself because it
Yeah.
pays for itself.
Yeah. Yeah. That makes sense. And so you're focused on sleep only. Would you have a sleep coordinator be the one kind of split their duties between coordinating sleep, scheduling for sleep, as well as billing? Or would you recommend having a dedicated billing person full time, or does that depend on your volume?
I would think that would depend on your volume and how well they were knowledgeable in the system of billing and things like that.
Okay.
I was very fortunate with the assistant that I had that runs my front office. She did a lot of medical billing through a DME company that supplied oxygen and CPAP masks and wheelchairs, and she knew Medicare in and out. She knew a lot
Okay.
about what insurance companies, would allow and not allow. And so it was just very easy for me to train her online through DS3. DS3 did a once a week class with her online, and that's how she learned to do her medical billing.
Okay. 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 So we've done our screening and paperwork, our Epworth, our stop bang, our bed partner. We've done our initial consultation. We've got verification of benefits. We've worked that into the initial consultation discussion about, what insurance covers, how to make this affordable. Let's say they have a $3,000 deductible and they have $2,000 left to meet it. They can't do $2,000 up front. Maybe you start talking about financing options, third party. Sleep study, obviously, depending on your state laws, that's you can either administer or disperse that yourself or refer out at your recommendation, referring to their primary care first.
Mm-hmm.
Are we moving on to step 4, or are there any other steps in between there that you think are important to highlight?
Well, once you get the sleep study results back, that's when you're moving on to step 4. Okay.
Okay.
So you have to have those results back. And remember, it doesn't matter who sends the test out, whether you or the primary care orders it. It has to be read and interpreted by a board certified in your state sleep physician. Okay. So once that's done and you get a copy of the results, whether they're on the cloud or emailed to you or whatever, you print them out, it. That's when you have your ammunition that you can sit down in the case presentation or the case consult going to talk about how to treat their problem. Whether they're mild, whether they're moderate, whether they're severe, and then you go and you move forward. Case being, yesterday I had a woman who tried wearing the CPAP. They couldn't. They tried moving her to a BiPAP because it's less invasive or not as hard on you. She couldn't. Her primary care basically said, well, there's nothing else.
Oh, geez.
And she happened to know someone else that had talked about wearing an oral appliance. And as soon as I didn't do it on them, but as soon as they talked about an oral appliance, she saw the Facebook. And that's when she called me and I got her right in, and we've already moved forward. I mean, we're down the road. We've got it approved. I did my scan on her yesterday, and 2 weeks from now, she'll be delivering a device. I'll bill it, and then.
Oh, you cut out, Cuffy.
All right, how are we doing now?
We got you.
Okay, so I just had a patient in. We did the consult. She saw us on Facebook. She couldn't wear a CPAP or a BiPAP, and now she knows there's an alternative, and we showed her. And so that's what we do in the case consultation and the presentation. Okay. So like I said, my practice is a little different because they're already coming to me looking for a solution. Okay. So I'm providing the solution. They're already looking for a solution. It's not like, they're unaware and they don't know, and they are aware, but they don't really have a solution and all that. So
you're not screening an existing dental patient. You got people coming in because they know they're a little bit higher on our sleep awareness level.
I am. But still, the people that are listening to us right now, most of them aren't sleep only. So they've got to start from step 1, do step 2, do step 3, and things like that. And then once we do the case presentation, and I can say how much you're going to have out of pocket, or you may not have any out of pocket, how much you have in deductible. I only do a couple cash cases every month. Okay. Cash price is $2,250. I try to make my cash price somewhere lower than what some of the higher deductibles are, so that if they pay me they're still getting treatment and they don't have to pay a lot larger deductible. And or the person may say, well, I may wait another couple of months because someone else in the family has to have this surgery, and now by then I'll meet the deductible, and then mine will be free. I'll say, no problem. Let's go for it.
Okay. Now you mentioned something earlier about the patient who just reached out to you, who tried the BiPAP, CPAP.
Yep.
You mentioned you did a scan on her. How does that play into the process? Where does that scan come in?
As long as I don't bill the scan, I can do things that are not directly within the steps, or I can combine 2 or 3 steps together.
Okay.
All right. Systematically, we know that when you have a process, step 1, step 2, step 3, but because I know where I won't call it cheat the system, but I know if I've got a patient that's coming in and they're ready to go, why do I need to bring them in another time just to do a scan when I can do the scan while they're here today?
Yeah.
And I use an iTero scanner, and I scan her upper, lower, and I also did that lady's pharyngometer that day. That is over on step 5. Okay, bite records. I did that day too, and she was 8 millimeters open and 4 millimeters advanced. So
okay.
We just combine them all, and then it gets sent out and done.
Okay. Now, do you have any preferences for, obviously in different clinical situations, you're going to provide different style appliances, or, at Medicare requires a herp style. Who are the labs that you like to work with?
I do a lot with Prosomnus. I do a lot with Glidewell. I do a lot with the American Medical Device Company out of New York. They do my Medicare stuff because they make a flat rate herp style for $299.
Okay.
Good price. That's a good price.
And
okay?
and quality's good?
Yes. Now, how do you determine what type of appliance to make for someone? Well, basically that depends a lot on the patient themselves. Are they missing any teeth? Okay. A EMA is a suck down type appliance. So it's a acrylic that's like made on a suck down model. And if you're missing several teeth, it's thinner in those areas, and you'll put more stress on those when you bite, and you'll probably break it. Right. So if you're missing any teeth, no EMA for me. Okay. I don't use those. Now, Prosomnus devices are milled. They're CAD/CAM milled out of a solid block of acrylic. And I don't care if you're missing teeth, you ain't gonna break that. Okay.
Yeah.
They're very durable. And if someone can't open real wide, you can't put a device in very good that's a one-piece device. Like a Prosomnus IA or a CA comes in 2 pieces, and you can put it individually so your mouth doesn't have to be open as wide.
Yeah. And those are pretty low profile.
Yes. And a herps has to be in 1 piece. So if you can't look real big, it's hard getting 2 pieces in there at the same time. Okay. It'd be like a general dentist trying to take his upper and lower impression at the same time. Okay?
I've had that done.
And if you're a grinder, certain appliances are not good for grinding. Any appliances that have vertical fins on them, like a dorsal fin or something like that, you'll break the fins off if you're going right and left excursions and grinding while you're sleeping. So there's a lot of things that we look at. That could be a whole 30-minute session on choosing appliances.
Sure.
Okay. So just food for thought.
Okay. No, this was really great, Cuffy. And I know you got a 1:30 tea time. So is there anything else just kind of that you would like to add to, this? Obviously this process is laid out by Sleep Group Solutions. You follow it. You've modified it to fit your patient as well as your own workflow.
Exactly.
What would you recommend to the office that is just establishing a workflow? Would you recommend they follow this to the T, or try and be dynamic in the way they implement?
Follow this to the T till you find out what works best for you.
Okay.
Because you've got support staff within your office that can handle this. You can do the screening, you can look at the screening, and then you can move them through your hygiene department. Then you could schedule them for a consultation. And then that just gives you a systematic workflow so that you know where they fall in, if you say, hey, where's Mrs. Jones at right now? She's got records coming up next week. Okay. Now, when you start getting to say, well, I can do this, kind of like name that tune, I can do that in 2 notes. Hey, I can do this in 2 appointments. I can do this in 3 appointments. Yeah. So once you feel comfortable that you can do all that, remember, if you don't have it done correctly with the insurance company, it does not get paid. So if you
Yeah.
miss something because you're trying to shorten appointments, you don't have a letter of medical necessity, you don't have an RX for the appliance, you don't have the letter from the doctor saying that they have to have a sleep study if it's needed, you're not going to get to bill that appliance.
Yeah. Now, do the billing companies that you've worked with in the past, do they provide you all of those details about what that particular patient's insurance requires of you as the practitioner?
Tell you if you didn't supply it to them. Okay. They have
Okay.
these things called smart sheets, and you have to check on a smart sheet when you've submitted something. And if you have not submitted it, they'll say, hey, I still need that. I still need
Okay.
that. And, just like us talking about dedicated sleep, all my things on dedicated sleep have to be entered in SOAP note form. And if it's not in SOAP note form and signed by the doctor, they kick it back to me.
Yeah.
Yeah. Now,
Okay.
other insurance companies don't need that.
Okay. So
Yeah.
that should be something that general practitioners should be able to expect from the billing companies that they're working with, those smart checkoff sheets, to make sure they're providing everything the insurance companies are requiring of them.
Yes. Yes.
Okay, great.
Yep.
All right, Cuffy. Well, it's 10:30 and you need to tee up. So
Well, if anybody has questions, like you said, just have them shoot them to me, and I'll be happy to get to them and send them back, and I'll answer them tonight if they come in tonight.
that would be great. I appreciate your time, Cuffy. Have a great game.
Todd, thank you very much.
All right. Talk to you later, buddy.